So some of this has already been covered by Dr. Kelleher, but just to say that there's a spectrum of illness. In fact, we probably don't see, except for the tip of the iceberg, there's probably a lot of people out there who have a milder form but don't seek medical care or aren't sick enough to present to us. But of the ones that we see, less than half recover, about a third recover partially, and about 25% are left with what we call the chronic course of the illness, where the focus goes away from recovery, but trying to keep them healthy for as long as we can. So the morbidity or the complications that we see, Dr. Kelleher is talking about the psychosocial, the behavioral, the cultural, but the part that Dr. McKay, Dr. Rosenbaum, and I deal with are the complications of malnutrition. The mortality rate for these patients is probably one of the highest in terms of what we see for people in that age group, so 5 to 15%, and this comes either from malnutrition, suicide, or alcohol abuse. St. Paul's data from 1981 to 2000 is right in the middle at 10%. Let's skip this one. So part of the assessment that we do when patients first come in is to see where they fit in terms of risk. We use more than one measure because if I just take somebody's body weight, different people will have the same body weight but not have the same nutritional level. So we say 100 pounds, so if you're 5'5" and a woman, you should be 100 pounds plus 5 pounds for every inch. That's an easy way to figure out what your weight should be. At a higher level, if we look at somebody's body mass index, we can look at what their height should be for what their weight should be for their height. But then again, some people might exercise so that their weight is increased, but that their fat level is decreased. So we also do body fat measurements. So we use all three of these measurements to help us get a sense of how severe this person is in terms of their eating disorder. We work with the dietitians, and they also help us figure out what the basal metabolic rate, resting energy, expenditure, and the daily caloric needs. So we're trying to figure out how many calories does this person need to maintain their weight or to increase their weight. And it comes out to a very simple supply-demand, and we're trying to achieve a balance. So on the supply side, we have decreased calories, decreased vitamins, and decreased minerals. On the demand side, depending on your age, you might be trying to grow but not given enough building materials. If you over-exercise, you might need more than somebody who doesn't exercise. When you become sick, your body needs more supply. Refeeding is going from a starvation state to eating again. And often patients who are not doing too badly when they're in starvation mode, we can make them worse by feeding them because all of a sudden you need all of these materials to build and they're not there. So all these deficiencies become manifest when you start to eat again. The other group of patients that we see are patients who are pregnant, and obviously there the demand is to build another individual. So what are the adaptations to starvation? Well, the first thing we see is that you decrease your basal metabolic rate, or the amount of calories or energy that you need just to maintain, and your resting energy. We see people's heart rates decrease, their blood pressure decrease, their body temperature decrease, and these are all adaptations to try and preserve your what's left of your body. We see hormonal changes. The preservation, when you're starting to use your materials or your stores, you tend to use the fat first, then you use your protein, and finally you use what we call visceral protein. And the visceral protein is the protein of the heart and the smooth muscle of the gut. So the role that we play in terms of helping the psychiatrist is helping manage the complication of, or preventing the complication of refeeding. We see patients who have long-term complications of their eating disorder. We see patients who have medical problems that interact with their eating disorder. So if they have, let's say somebody has diabetes, which requires you to manage with diet, exercise, and you add eating disorder to that, it becomes a very complicated endeavor to treat that patient. Also, if patients get acutely ill. We also participate in monitoring the chronic patients, the ones who have severe low weight, or we tend to take what's called a harm reduction approach. So the goal for those patients may not necessarily be recovery, but it may be keeping an eye on them to make sure that they maintain a minimum amount of nutrition so that they can stay at least healthy. So refeeding is the supply-demand problem made worse. All of a sudden, somebody who's gone from starvation, you boost their metabolism, or you put them in what's called a hypermetabolic state. They need all these building blocks that are not around. Deficiencies become unmasked. What you're doing is you're reversing all those adaptations that have taken to try and preserve your body. The problem is the heart may not be strong enough to help take care of all of this, because the heart is the one that adapts most slowly. So the problems that we see with refeeding are related to electrolytes, or the salts in the body, heart problems, brain problems. We sometimes see low blood sugars and even death. So the goal with refeeding is prevention rather than treatment. We have protocols in place, so this is not something that we, in fact, almost ever see. And if we do see it, we see such a mild version of it that we can intervene, because there's two ways that we can intervene. We can replace the building blocks, or we can slow down the feeding process so that the demands are not as high for what the person has. So we follow patients very closely, usually blood tests every day when they first come in, electrocardiograms to check their hearts. So if we look at the medical complications, apart from dealing with the refeeding, there's a whole list here. And the first one is the electrolyte problems. And that's just a problem with body fluids and salt. So somebody who's not eating may start to have a problem with potassium, magnesium, calcium, a lot of what we call the ions or the salts in the body. Patients who abuse laxatives or who abuse diuretics may lose some of those electrolytes in their stool or in their urine. Patients who are binging and purging lose them when they vomit. And so you might say, what's the big deal about electrolytes? Well, electrolytes run all of the electrical impulses in our body, so that you can have problems with sudden death, arrhythmias, seizures, things like that. The heart problems. So the first thing that happens with malnutrition is the heart decreases in size and its functions decreases. Also, because of the shape of the heart changes and the muscle is less, there's less structure to hold the valves in place, so that the valves can become floppy and not operate completely well. If you starve the heart for too long, then some of the muscle fibers actually get replaced by scar, and that part may not be reversible. What we see is this turns out with low heart rates, so we see patients whose heart rates may even be as low as the 30s, and low blood pressures. This can lead to dizziness, fainting, congestive heart failure where the heart can't pump well enough, arrhythmia, sudden death. And this is the organ that we're most fearful of during the refeeding syndrome. Endocrine or hormone complications. So the fat in the body, and especially for women, is an endocrine or hormonal organ. And there's a certain amount of fat for women that we call essential body fat. Below that amount, you don't have enough body fat to help with producing female hormones. And that's why we see patients who, if their weight gets low enough, and it's one of the criteria to make a diagnosis, is we see that they lose their periods. If you lose your periods for more than a year, you're at high risk for osteoporosis. The other thing is that because young women get their peak bone mass, so as you're getting towards your adult size, you fill your bones with calcium, and then over a lifetime, it decreases, and by the time that you're in your 60s, 70s, 80s, it's much decreased. So you can imagine that if you don't reach a very high peak because your nutritional intake is not very good, or because you don't have the hormones around that help you put the calcium in your bones, that you're going to be at risk for osteoporosis later on in life. So this is the most significant long-term complication, and it's not completely reversible. And we talked about the peak bone mass. So hypoglycemia, the low blood sugars, and this can occur during refeeding, but we have some patients who get this even when they're not trying to actively gain weight or increase their body mass. It may be a problem with the fact that the liver doesn't have enough sugar to respond whenever the sugar goes low, but it's a lot more complicated than that. It's one of the feared things that we see, because patients who die tend to have problems with sugar in and around the time before they pass away. So neurocognitive or brain effects. So here's an example of what happens to somebody's brain when they're starved. You can see that the folds are much more prominent and that there's a lot more space between things. So what we see with that is shrinkage of the brain. This can lead to a personality change. We can often see patients, we can tell when patients are getting to that point where they're just too much, because when you speak to them, it's almost like it's taking extra time for the brain cells to fire and to get the response. So you ask a question, and it's almost like you feel they haven't heard you, and when you're about to ask it again, finally the answer comes out. There's very much this slowing of the interaction. So the other thing that happens is that the chemistry of the brain changes. When I first started seeing patients like this, my thought was that, well, here are these small, young women who are very malnourished, so that the amount of medication that we would need to treat them would be minute. And it's in fact the opposite. So for a lot of the medications that the psychiatrists use in these patients, that they actually don't work very well until we can get their weight back up. And often we don't even try and engage them in some of the psychological work until we get their weight back up, because we know that their brains are not in a place where they can participate, and that we need to get their weight back up so that they can think properly and that the medications can work properly. In terms of the kidneys, and Dr. Rosenbaum is a kidney specialist, one of the things that we see is a lot of these patients, in addition to restricting food, also restrict salt and restrict liquids. And so they can get chronically dehydrated. And dehydration over a short period of time for the kidney is not usually a problem. It's usually reversible. But you can think that if you're starving your kidney for so long, and it's almost like choking it, that it's not getting enough oxygen and enough supply, that after a while, slowly but surely, you start killing off the cells, and you can get chronic renal failure, so the same as somebody with diabetes or with blood pressure problems. The other thing we see is the patients who abuse diuretics, and that although they know that it doesn't help with their weight, they somehow become addicted to using these medications as a way of dealing with issues. Problem is that it's not always reversible. In terms of the gut, and the gut becomes a really interesting point, because a lot of these patients already have issues with wanting to eat and feeling bloated, and sensations of constipation, and so what happens with malnutrition is that the gut is basically a tube that's surrounded by smooth muscle. After you've wasted the muscle in your arms, legs, and the rest of your body, go for the heart, go for the bowels. So the bowels are not working properly. The stomach doesn't empty very well. The bowels don't move the food through you very well.
Your attention, all visitors. It is now 8 p.m. Visiting hours are now over. Thank you and good night.
So when the stomach or the esophagus don't work properly and it doesn't empty, you can have food refluxing back or acid refluxing back. You can have feelings of bloating, fullness. And these things become worse when they start to eat again, because now they're needing to deal with a larger load of food. But it's almost like thinking about if you were lying in bed for several weeks and your muscles become deconditioned and all of a sudden you're asked to walk upstairs, you're going to have a hard time. So going from the starvation state to being refed often takes a while for the bowels to get going again. In terms of the hematologic or the bone marrow, every one of the cell lines can be affected. Patients can become anemic. They have low hemoglobins. This may be because of not having vitamin B12, folate, but sometimes it's just the malnutrition itself that they're not building. The white cells can be low, and this can persist even after we start to get their weights back up, and this can make them prone to infections. So the role that we play is to be one of the partners that help the psychiatrists in taking care of these patients. We participate on the ward in what's called the extra care program, but sometimes, as we mentioned before, some patients are not ready to participate in recovery, and that the role right now is just to get them medically stable, so we'll admit them to the regular medical wards of the hospital. We have a medical assessment clinic, and we see all of the patients who are referred to the St. Paul's eating disorder. And as Dr. Kelleher told us, the initial assessment includes a psychiatric, a research, and a medical assessment. We have a medical monitoring clinic where we'll follow the low weight or the chronic patients. We'll follow patients who have medical complications or patients who have problems interacting with their eating disorder, and patients who are pregnant. Dr. McKay and Dr. Kelleher look at the very tip of the iceberg, the complex care clinic, the most difficult patients. We also have an outpatient tube feeding program, and we provide provincial advice.